It is my great privilege to welcome Dr. Gurudutt Sir, Professor of JSS Medical College, Mysore, to deliver the talk on the topic Intraoperative Diet Bag, How to Proceed. A warm welcome to you, sir.
Good evening. Good afternoon or good evening, everybody. You know that it's not there. So intraoperative tight bag, or you can say a sudden increase in the peak inspiratory pressures, is not an uncommon situation you all come across during our day-to-day practice. But when it occurs, don't think that it is always intraoperative bronchospasm and try to treat it. There are so many other causes which can produce a sudden increase in the peak inspiratory pressure, and if you are managing with a bag and or manual ventilation, it can produce a tight bag. You will not be able to ventilate. So how are you going to proceed in such situation? It is always better. We always try to know what are all the causes which can produce a sudden increase in the peak inspiratory pressure. First, try to rule out all the causes, and then you can think it can be intraoperative bronchospasm and you can treat, because the management of bronchospasm and management of all other causes which mimic a sudden increase in the intraoperative peak inspiratory pressure can be totally different. So what are all the causes? One of the most important causes, slightly reduced. One of the most important causes can be an obstruction of the endotracheal tube, and this obstruction of the endotracheal tube can be external obstruction or internal obstruction. You all know that the external obstruction of the endotracheal tube, the most common cause is kinking of the endotracheal tube, and where the kinking occurs, most common position where the kinking occurs is where we have fixed the endotracheal tube to the right angle of the mouth, and that is one position, and it may also be because of the poor quality of the endotracheal tube. And kinking occurs, other reasons why kinking can occur is it can be a head and neck surgery where the surgeon may be applying some pressure over it, or instruments can also be producing the kinking, or we are having surgery in position other than the supine posture. It can be lateral or it can be prone. In all these other situations also kinking of the endotracheal tube can occur. But in all those situations, what we are going to do is we will be using an armor tube. Do you think that the armor tube will not produce a kinking? We will not produce kinking. It can also have sudden kinking can occur, especially if the patient is on spontaneous ventilation, he has not been relaxed, and suddenly bites the tube, and it will be a permanent kinking, and you will have to actually change the tube. Other place where it can kink, where the connector has entered the tube. Actually there the spirals would not have started there. That is a place where an armor tube can kink and produce obstruction. The third place where armor tube can produce obstruction, you can see the invariably in the armor tube, the cuff is slightly more distally placed. Because it is more distally placed, and if you increase the amount of volume of air you introduce, herniation of the cuff into the bevel, and it can also produce obstruction. The other thing, internal obstruction that can occur. So internally it can obstruct because of a mucus plug. You all know that in patients with bronchiectasis, in patients with chronic bronchitis, and especially in those patients mechanically ventilated in ICUs, this is all very common, the mucus plug obstructing the endotracheal tube. The other thing, the foreign body, and this used to be very common in those days where we were using only the red rubber endotracheal tube. So we had to reuse the red rubber endotracheal tube every day, the same tube, and many times as soon as we used to come and we used to put it against the light, and then Dr. Aruna is smiling, and then we had to see through and through. Then only we would be sure that nothing is there, because we have found even cockroaches inside the endotracheal tube, and many times even the cotton plug which was used to clean the endotracheal tube, it used to be there. But nowadays, because we do have transparent endotracheal tubes and not reusable endotracheal tubes, this problem is not there. But when you use an nasotracheal intubation, again the adenoids may come out and they may block the endotracheal tube. So, this is one thing you should always realize. The other thing is the North Pole RAE tube. North Pole RAE tube, many times it comes as an opaque tube. So, there is a case report recently that they have opened a new North Pole RAE tube. They tried to they have intubated, they tried to ventilate, they were not able to ventilate. They gave, they thought that it is the bronchospasm, and then they gave 10 puffs of beta 2 agonist, nothing happened. They just have to pull out the tube, and they found out that internally there was total blockade of the RAE tube. So, that is because it is an opaque tube, you cannot make out. So, other thing is, the bevel abutting against the anterior wall or the lateral wall of the trachea, because the tube has got the curvature. When you introduce, it can go and abut against the anterior wall of the trachea or lateral wall of the trachea, because the bevel is always facing the left. So, this is one of the possibilities that can occur even intraoperatively. So, that is the reason why we have a Murphy sign. So, this was very common in those days. That is the reason the Francis John Murphy introduced this in 1941, and from 1951 onwards all the tubes you do have the Murphy sign, but many of the pediatric tubes may not have Murphy sign. So, this is a possibility you should always think about. You all know about the endobronchial intubation, again can be a cause for sudden increase in the peak inspiratory pressure, and this is endobronchial intubation. You all know that it is more common in pediatric age group, because the length of the trachea is just 5 centimeters. So, just half a centimeter going inside, it can go into any of the bronchus, because the angle that is formed is 55 of the bronchi with the trachea. Whereas in an adult patient, it can move on to the right bronchus, because the right bronchus forms an angle of 25 degrees with the trachea. So, invariably, how do we know that? It can be endobronchial. So, if you ask the chest will be moving on only one side, right side, left side chest will not be moving. If you try there won't be any sounds on the left side, and if you try to percuss, there will be dullness on the left side. Why I am telling dullness, you will have to know about another cause, you will have to differentiate, is the pneumothorax. That also can produce a similar situation, and the pneumothorax can be a closed pneumothorax, especially in a patient with COPD with a bulla, and we go for positive pressure ventilation, the bulla may rupture and can produce a closed pneumothorax, and it can be even a tension pneumothorax. So, how do we differentiate endobronchial intubation with tension pneumothorax, because this is a real emergency. Endobronchial intubation, you just pull out by half a centimeter, 1 centimeter, everything will be all right, but not so with pneumothorax. So, pneumothorax, on the affected side, definitely the chest will not be moving, there won't be any respiratory sounds, but if you percuss, definitely the hyporesonance will be there for percussion, and also it can be accompanied by hypotension and tachycardia. So, if such a thing occurs, and there can also be a mediastinal shift also. So, it is an emergency, so immediately you will have to act. So, you can take a larger bore cannula, 14 gauge or 16 bore cannula, put it in the mid-clavicular line in the second intercostal space, connect it to an underwater seal, or you can definitely afterwards, you can go for a definitive chest drain for such cases. The other thing is pulmonary edema. Just now I was asking a question about pulmonary edema. Also can be a cause for sudden increase in the peak inspiratory pressure intraoperatively, and especially in patients. Just now we had a cardiac case. So, cardiac disease patients, morning we were having a CK, also can have the pulmonary edema, because hypoalbuminemia and preeclamptic mothers highly prone for preeclampsia, and other causes also can be overload, or it can be a negative pressure pulmonary edema if you had a very difficult airway in the beginning, and that can lead to pulmonary edema, and you can have a increase in the peak inspiratory pressure. And just now we discussed how a pulmonary edema case also. Huh? Take it. Okay. So the other cause is aspiration of the stomach contents, and especially so in those patients where you have a full stomach patient, you have taken all precautions, and you have even gone for a rapid sequence induction, you applied the cricoid pressure, but still there is always a possibility that the aspiration can still occur, though less chances. But if you find when you do a laryngoscopy, the food contents in the pharynx, you can always think that can be one of the problems. So one more thing which we usually do not think about the woody chest. Now, one of the students was telling, I'll be going for 4 micrograms per kg body weight of fentanyl. So if you give 4 mics very rapidly, that can lead to woody chest, and before you have even intubated, and then you are managing the patient. If that you think as a cause, you just relax the patient, and the chest will become relaxed, and you can easily start ventilating without much of peak inspiratory pressures. The other thing is, in a COPD patient, for example, the autopeep that can occur. In a COPD patient, you have to give prolonged expiratory time because the time constant for expiration is prolonged. Suppose if you have not kept that, and then there will be dynamic hyperinflation, and the patient can develop autopeep, and you just see the scalars or the flow volume loops. The expiration is not ending before that the inspiration is starting. You know that the patient has gone for autopeep. So what you can do is, you just disconnect the circuit from the endotracheal tube for few seconds, reconnect. In the meantime, you adjust the expiratory time, slightly prolonged expiratory time, shorten the respiratory rate, everything will become settled. Then, in patients, with pneumoperitoneum, of course, pneumoperitoneum is going to push the diaphragm up. That is going to reduce the vertical height of the lung, and that can produce a decrease in the compliance of the lung. And any decrease in the compliance of the lung with the same amount of pressures you are using, same amount of tidal volume, is going to increase the peak inspiratory pressure. So the other thing is, the surgeons, if they are using the the retractors, especially the upper abdominal surgery or tight abdominal packs, also can produce this problem you should be aware of. And the most important thing again, lighter planes of anesthesia. I always keep telling my students, whenever you are asked about a cause for any particular complications intraoperatively, first thing you say lighter planes of anesthesia, you always will be correct. And lighter plane of anesthesia can produce all kinds of complications. It can produce havoc. So it's very important you maintain a good depth of anesthesia for such things. And if you rule out all these things, now you can think about perioperative bronchospasm. So it is one of the most feared complications because the mortality can be very high, and in approximately 9% of the bronchial asthma patients they can develop. But what is very important is prevention, recognition, and proper management. They are very crucial. Now, how do we prevent an intraoperative bronchospasm in a patient who is prone for intraoperative bronchospasm? How do we know which patient is prone for intraoperative bronchospasm? So you just do a proper assessment of the patient. So take a history. The patient has got an atopic history or an allergic history, yes, he is prone for that. And just if a patient is an asthmatic, you just ask how frequently he is using his asthma medications. If he is using almost 3 to 4 times a day his asthma medications for control of his bronchospasm, that is the patient who is likely to develop an intraoperative bronchospasm. Then, if the patient for acute bronchial asthma, he has been admitted to the hospital recently, and if when he is admitted, he required an endotracheal intubation and managed in the ICU, that means he has gone for respiratory failure. And if that has occurred within 1 month or 2 months, and such is a patient, he is likely to develop intraoperative bronchospasm. Smokers, you all know about, and patients with upper respiratory infection. That is why it is said that if a patient gives history of upper respiratory tract infection, usually you postpone the surgery for at least about 4 to 6 weeks. Then one of the tests you can do is a Wheeze test. You ask the patient to take 5 deep breaths and auscultate on the back. If you find rhonchi, you have to be careful because this is the patient who has got a hyperreactive airway. And other thing is you ask the patient to cough, and if voluntary cough is followed by repeated coughing again, then this patient will have a hyperreactive airway disease. You do a blood test. If absolute eosinophil count in a bronchial asthma patient is more than 500, you have to be extremely careful, better to postpone, treat if it is an elective procedure. And if the patient has got, at present wheezing, you should never post him for any kind of, elective procedure. Only life-threatening or limb-threatening surgeries you should always undertake. So best thing is, another way of prevention is give them inhalational beta-2 agonists and then steroids. They are very effective in preventing intraoperative bronchospasm. The other thing is, if the patient has got persistent airway obstruction, like continue to have bronchi, you can put him on oral steroids, at least 0.5 to 1 milligram per kg body weight of prednisolone, at least for about 5 days. Even on the day of surgery, you continue. That is going to prevent intraoperative bronchospasm. Coming to the anesthetic technique, yes, regional anesthesia is ideal, but I have had 2 cases of severe bronchospasm in those patients who never had bronchospasm in their life after interscalene brachial plexus block. Maybe we were using high volume of local anesthetics. Probably the incidence must have come down drastically now. Then use of supraglottic airway device. Definitely, if you think that the patient is prone for intraoperative bronchospasm, do not intubate. If possible, you can manage with a supraglottic airway device. That is always better. Because you know that when you intubate, you are going to stimulate the mechanoreceptors. The impulse is carried to the nucleus solitarius in the brain and to the vagus nerve. And from the vagus nerve, the nerve endings are going to release acetylcholine. Acetylcholine acting on the M3 receptors in the bronchi is going to produce the bronchospasm. So in all that situation, preoperatively, we just give 1 milligram per kg body weight of lidocaine IV and deepening the plane of anesthesia. And also I told you about beta-2 agonists and ipratropium or glycopyrrolate going to help in preventing this vagally mediated bronchospasm. Coming to the induction agents, you all know that we have various induction agents. We have thiopentone, etomidate, ketamine, propofol. Propofol scores over all other drugs, definitely. But thiopentone is relatively contraindicated because it sensitizes the upper airway reflexes. But if the patient has got hemodynamically, he is unstable, then one can go for etomidate without any choice. So then coming to inhalation anesthetic agent, no desflurane. Don't use desflurane. All other inhalation anesthetic agents are fine. Isoflurane, sevoflurane, and halothane are fine. Then muscle relaxants. Yes, we can use muscle relaxants like vecuronium or rocuronium. Succinylcholine, 2 molecules of acetylcholine, you have to be careful. Theoretical possibility of inducing bronchospasm is there, and atracurium better to avoid in such situations. Reversal agents, yes, neostigmine. Lot of people were thinking whether to give neostigmine or not, because neostigmine increases acetylcholine levels. That can induce theoretical possibility again, but we have used neostigmine and glycopyrrolate for many number of asthma patients without any problem. So Sucamadex probably an ideal agent because no residual neuromuscular palsy, but you have to be careful. It can induce an anaphylaxis. So recognition, how do we recognize intraoperative bronchospasm? So wheezing and auscultation, elevation of peak airway pressures that we are discussing now. So if you take the bag manually, there is increased resistance. If you are leaving the patient on a positive pressure ventilation, there is going to be a decrease in the tidal volume, decreased SpO2, desaturation will be occurring, and the EtCO2 can show a shark fin appearance. So how are we going to manage intraoperative bronchospasm? So increase the FiO2, make it 100% because invariably desaturation is very common. Take the bag manually from mechanical ventilation because you can appreciate the compliance of the chest and the lung better by your hand rather than putting the patient on mechanical ventilation. Ask the surgeon to stop surgery because it can be because of lighter planes of anesthesia, surgeon manipulating. It can be because, and then use beta-2 agonists. So one thing about beta-2 agonists, you should not, if you are using a metered dose inhalers, you have to give 10 puffs of meter dose inhaler because there is a raining out of the drug in the endotracheal tube. Questionable use of intravenous aminophylline. Intravenous corticosteroid, definitely you have to use, but it will not act immediately. It will take some time. IV ketamine, 0.5 milligram per kg body weight, bolus, and 0.5 milligram per kg body weight as an infusion you can give. IV lidocaine definitely can be used, 1 milligram per kg body weight, bolus, and 60 mics per kg per minute for next 20 minutes and 30 mics per kg per minute for next 2 hours, and after that 15 mics per kg per minute. 2 grams of magnesium sulfate also can be tried in resistant cases. Then IV adrenaline 10 to 100 micrograms can also be given. So last resort will be ECMO. So another thing which, and you may be asking me how beta-2 agonists can be administered, especially the meter dose. You can have, specially designed adapters are there. That adapters, another 3 minutes I'll take. Specially designed adapters can be used for the meter dose inhaler to be given. 10 puffs you have to give. So another thing one can use is Heliax. You know that Heliax has got a decreased density compared to oxygen and air, and oxygen also, because any decreased density the flow can be better, especially the Graham's law as far as the turbulent flow is concerned. So Heliax can be used, and of course Heliax has got a lot of advantages in COPD patients, like it can decrease the PIP, it can definitely decrease the autop, definitely you can reduce the respiratory rate because tidal volume will automatically increase. And this is the dyspnea index, how it can decrease with Heliax. And one more advantage of Heliax is better distribution of bronchodilators when you use. Anaphylaxis is another thing which can produce intraoperative tight bag. So if it occurs, of course, severe bronchospasm will be there associated with hypotension and tachycardia. That is, you can make out definitely, and there will be a cutaneous features of rashes will be there. So consider IgE mediated anaphylaxis, stop anesthetics if possible, because one of the most common drugs which can produce anaphylaxis are muscle relaxants, vecuronium, rocuronium. Of course, rapacuronium was withdrawn because it used to be a notorious agent, mivacurium. So that's how, these are the things which you have to be careful about. Increase the FiO2 to 100% position. Here, you will have to put the patient into Trendelenburg position because the patient will be in a highly compromised hemodynamic status because severe hypotension. You have to use epinephrine and fluid therapy. Methylprednisolone can also be used. Extubation, should we extubate or not extubate? It all, before extubation, give repeat salbutamol. Very important is adequate analgesia. Dexmedetomidine definitely can help before reversal and then extubating. And reversal again, I was already telling you, Sugammadex may be a better one, and it is always better to go for deep extubation. That means you have reversed the patient from neuromuscular blocking agents, but still you keep the patient deep with inhalation anesthetic agents, because before we usually advocate the patients to be extubated completely awake, but deep extubation is possible now by Bailey's maneuver. So you just put a supraglottic airway device behind the endotracheal tube, inflate it, take out the endotracheal tube. That's how you can extubate the patient when the patient is in deep plane of anesthesia. So post-op mechanical ventilation, if the patient continues to have bronchospasm, you can shift him to ICU, continue with the post-op mechanical ventilation. And just to conclude, perioperative bronchospasm can occur in hyperreactive airway diseases. Regional anesthesia is a preferred choice. Of course, supraglottic airway devices can be preferred. And what is most important is keeping the patient with deep plane of anesthesia. And rule out all other causes. All that glitters is not gold. So all that produces tight bag is not bronchospasm. Rule out all other causes. Every cause has a different method of management. Thank you. Thank you so much. Hydrocortisone, because rapidly acting. Yes. For anaphylaxis, better to go for methylprednisolone. Yes. Aminophylline. No, aminophylline I mentioned. Deriphyllin also, but when you have aminophylline, it is always better to give aminophylline. And what we have found is in certain resistant bronchospasms, aminophylline does help. But the problem again with aminophylline is the dysrhythmias, especially ventricular dysrhythmias. That is a big problem.
Thank you, sir.
Thanks for extra time.
Now I invite Dr. Thomas George onto the stage to felicitate Dr. Gurudutt sir.